Hey everyone, and welcome. If you've ever found yourself wondering what actually happens during a breast biopsy, well, you are in exactly the right place. Today, we're going to pull back the curtain on the technology, the techniques, and all the thinking that goes into this incredibly important procedure.
Okay, so let's be real. Hearing that a screening found something and that you need a closer look, that can be really stressful. The word biopsy alone can cause a ton of anxiety. But understanding what's going on, that's where the power is. Our goal today is to replace that feeling of uncertainty with clear, straightforward information. We're going to walk through exactly what happens, step by step.
So here's the game plan. We'll start by looking at the two main tools radiologists use. Then we'll dive deep into ultrasound-guided biopsies. And after that, stereotactic biopsies. We'll even walk through a super common what-if scenario involving cysts. And finally, we'll cover what happens right after the sample is taken.
Right, so when a biopsy is necessary, radiologists have two primary methods they can turn to. And it's not like they just pick one out of a hat. The choice depends entirely on what exactly they need to get a closer look at. First up, you've got the ultrasound-guided biopsy. It's usually faster, and it's the go-to for any masses you can see on an ultrasound. Then, on the other side, you have the stereotactic biopsy. This one uses mammogram imaging to find its target, which makes it the absolute best method for investigating those teeny tiny calcium deposits called calcifications. So here's the bottom line. The finding determines the tool.
All right, let's break down the most common procedure first, the ultrasound-guided biopsy. This whole technique is about using sound waves to get a live, real-time picture of what's going on inside. It's like having a live video feed, giving the radiologist a crystal-clear view of exactly what they're doing as they're doing it. Now check this out. The tool they use is pretty cool. It's not just some simple needle, it's this sophisticated spring-loaded device. The whole idea is that its automated action can grab a coarse sample of tissue really quickly and cleanly, which gives the pathologist a great, consistent sample to analyze.
And this slide really shows you just how precise this has to be. For this to work, 4 different things have to be perfectly lined up on the screen at the same time. You've got the lesion itself, the ultrasound wand on the skin, the tiny entry point, and of course, the biopsy needle. It's kind of like lining up the perfect shot in a video game, just with much higher stakes.
And believe me, none of this is guesswork. It's a super refined technique. Just look at these best practices. They keep the needle parallel to the chest wall. Why? Well, to stay far, far away from the lung. They numb the area around the lesion, but not in it, so they don't hide their target. They always biopsy the deeper part first, because if any bleeding happens, it won't obscure the rest of the spot they need to sample. Every single move is deliberate, all for the sake of safety and accuracy.
This quote from our source material really just hammers home the #1 rule: safety above all else. If, for whatever reason, the radiologist loses sight of the target, like in this case by accidentally injecting a little air, the whole thing stops. Period. You never proceed blind. The patient's safety and getting an accurate result are way too important, so you just reschedule. Okay, let's switch gears. What happens when the target isn't a visible mass, but something way smaller, like those tiny calcifications? Well, that's when the stereotactic biopsy shines. Instead of sound waves, this method uses mammography, low-dose X-rays, to create what's essentially a 3D map. Think of it like using a high-tech GPS to pinpoint the exact coordinates of something you can't even see otherwise.
So what's really great about this procedure are all the built-in checks and balances. Yeah, the breast is compressed, but usually less than for a regular mammogram. But here's the absolute game changer, the part that makes sure it all worked. They X-ray the samples right then and there, in the room. This confirms on the spot that they captured the tiny calcifications they were after. It's an instant verification. And on top of all that, the machine's targeting system is tested for accuracy every single day. It's all about precision.
Okay, let's talk about the hardware for a sec. The gauge is just about how thick the needle is. And it's a little weird. The smaller the number, the thicker the needle. Now, why does that matter? Well, it's basically a trade-off. As you can see, if you use a thicker needle like a 7 to 9 gauge, you only need about 4 samples. With a slightly thinner one, you'll need more passes to get enough tissue. The goal is always the same, though. Give the pathologist the absolute best tissue to work with. And once again, you can see how safety is the top priority. So what happens if the breast tissue is really thin when it's compressed? Well, the system is smart enough to see a potential problem, a situation where the needle could literally go all the way through. To make absolutely sure that doesn't happen, the plan changes. They'll switch to a different procedure entirely. It just goes to show you, it's always about choosing the safest, most effective path for the patient.
All right, let's walk through a super common what-if scenario that radiologists deal with constantly. I like to call it the cyst conundrum. This is the classic challenge of figuring out if something on an ultrasound is just a simple, harmless, fluid-filled cyst or if it's something more solid that needs a biopsy.
And here's why it's a conundrum. 70%. Let that sink in for a second. Even after a simple cyst is drained with a needle, there is a 70% chance that it's just going to fill right back up. That one fact really frames the whole decision-making process.
So the radiologist is looking at the screen and they see something. It could be a solid mass, or maybe it's just a cyst with some gunk in it, which can sometimes look the same. So what's the first move? It's always the simplest one. Try to aspirate it. Just see if any fluid comes out.
So let's follow the happy path here. The needle goes in, some clear or yellowish fluid comes out, and when you look back at the ultrasound screen, poof, the lesion is completely gone. This is the best-case scenario everyone is hoping for.
And the conclusion is just as simple and clear. That's it, you're done. The fluid can be thrown out and the diagnosis is confirmed it was just a simple cyst. No more steps needed. Case closed.
But, okay, what if there's a wrinkle? The lesion still disappears after you drain it, which is great, but the fluid that comes out, it's bloody. This changes things and calls for a bit more caution.
So there's a two-part plan. First, that bloody fluid has to go to the lab to be checked out under a microscope. And second, a tiny little marker clip is placed in the exact spot where the lesion was. This is so important because if the lab report comes back with anything concerning, doctors know exactly where that spot was.
And look, the logic just keeps going. If the fluid looks like pus, it gets sent for a culture to check for infection. And what if you drain some fluid but the mass is still there? Well, now you know there's a solid part to it, and the very next step is to biopsy what's left behind.
So we've got the sample, but we're not quite done yet. The procedure doesn't end the second the needle comes out. Let's talk about the final, super important steps that happen right there in the room.
After every single biopsy, a tiny metal marker, it's about the size of a sesame seed, is left behind at the exact site. Then, one last mammogram is taken, just to make sure it's in the perfect spot. Think of this clip as a permanent landmark. If the results mean surgery is needed, this marker literally tells the surgeon, go right here. They even check to make sure the clip hasn't shifted around.
So as we wrap this up, just think about it. From the perfect alignment of a needle, to instantly X-raying a sample, to the logical decision-making for a tricky cyst, every single step we've talked about is designed for one reason: to use technology and skill to replace uncertainty with clarity. These procedures transform that scary moment of what if into a clear path forward. And I really hope this explainer has made that path a little less mysterious for you.